Uh, there we go. It's my pleasure to be with you all today and to have Dr. Robison here with us. Dr. Robison is the medical director here at Center for Change. He's a lovely human. He's super kind, really, really smart, and is so careful and kind with our patients. And we're really lucky to have him. So I'm really excited to be able to have him present today on this great topic that I know we have a ton of interest in. And so I'm going to turn it over to Dr. Robison. I'll let him introduce himself a little bit more. Dr. Robison, you can go ahead and I'm going to go ahead, excuse me, and mute my mic and turn off my camera. But if you need me, I'm right here. And otherwise, I'll see everybody at the end of the presentation.
Thank you. It's good to be here, and thanks everyone for joining. I'm excited to chat about ARFID today, and I'll admit this is my first time doing this webinar on this topic, so it's been not only a fun deep dive, but um, I've also realized that it's a bit of a complicated topic. So let's make it, hopefully it'll be interesting, and I'll leave plenty of time for questions at the end. Put them in the chat as you go if you'd like. But first of all, what is this thing called ARFID? I think it's a funny sounding name, kind of fun to say, but and it came as a much needed diagnosis. I'll explain more on that um, in recent years. But one way to think about ARFID would be extreme picky eating that doesn't resolve. It's not about being afraid of gaining weight. It's a difficulty with the eating itself. So, um, I, I guess by way of intro and disclosure, before I get too much into the topic itself, I'm a psychiatrist and have been medical director at Center for Change since it's been maybe 9 years, 9, 8, 9 at least, and have really enjoyed the journey at Center for Change and the heart of the center, the people we work with. And I'll talk a little more at the end and probably in questions about how we approach ARFID and some lessons we've learned over the past year or so since rolling out kind of a specialized track. And Otherwise, I do clinical research. I split my time kind of half and half these days, studying new medicines, trying to find new treatments, and working with folks with eating disorders. And at Center for Change, we feed approximately 100 people a day across the inpatient, residential, day treatment programs. And on average, lately, about 20% or so have ARFID. And and let's see, by way of disclosures, because I do research studies, I do have funding from a number of pharmaceutical companies. I don't think any of it is relevant to this discussion, but I just want to be open and I consult for Janssen on and speak on S-ketamine. I do psychedelic research studies with psilocybin, LSD, and other compounds for folks like Compass, Beckley, MindMed, Usona, and just want to make sure that's all appropriately disclosed and well managed. Um, and then let's just jump back into the topic, ARFID, Avoidant Restrictive Food Intake Disorder. Um, it's interesting. Of course, we have Chat GPT these days, and I'll admit that I find it useful to summarize journal articles, save me some time in perusing a dozen different articles. And it's interesting. I was feeding it some references and having it summarize some things, and ChatGPT said something that made me pause. It's like, um, RFID is the only eating disorder without a body image component, um, or something like that. I was like, wait a second, that's not accurate. And so I pushed back on it, and it's the only restrictive eating disorder without a body image or say fear of weight gain component for most people. Um, and as I've highlighted here, it's not driven by the concerns about body weight and shape, unlike anorexia, for example. And there are three main kind of categories of ARFID. ARFID arise from these three main driving forces. One would be sensory sensitivity, like an aversion to texture, smells, tastes. Another would be um, fear of the consequences of eating, adverse consequences like choking, vomiting, pain. It could be a post-traumatic development of an eating disorder after say a scary choking incident. Um, and then the other category is lack of interest in eating. So low appetite, forgetting to eat, unable to really physically feel able to. Um, so individuals with ARFID may be avoiding food because it looks or smells repulsive, because they're afraid of choking, vomiting, or simply because they do not feel hunger. Those cues may be somewhat absent or very distant for them. Um, and then, like any mental health diagnosis, and like I mentioned at the onset, extreme picky eating that doesn't resolve. Picky eating is a normal part of growing up. And you could even say extreme picky eating in some cases. For example, I was at a family dinner on Sunday, and it was uh, it was my niece who asked a question about their little toddler, saying that over the recent months, their young boy, um, if coughing, needs a cup of water nearby, or he'll throw up, for example, and is struggling to eat and things like that. It just kind of got tied to this vomiting, but they see that they believe it's a mental thing in him. Like if he doesn't necessarily need the water cup can be right there, but it's I think anyone who has kids knows that it can be a battle on a very individualized basis for each kid on trying to get them to eat variety. But in ARFID, there's not only the extreme picky eating that doesn't resolve, but there are nutritional deficiencies, significant weight loss, or stunted development, or dependence on things like feeding tubes in extreme cases, or even dependence on supplement drinks to get nutrition. And as you can imagine, there are often and kind of need to be for the diagnosis to be valid, um, these impacts on life, including psychosocial impacts, avoiding social events, difficulty eating with others, maybe even missing school or work. Um, and it can affect children, adolescents, adults, and is often, as many people have heard and associated already, often associated with anxiety, autism, GI conditions, and the severity, like any condition, can range from mild to quite severe. And it's not uncommon that we have people in our facility, say on the inpatient unit, for example, with a feeding tube for a time with this diagnosis. And one reason I was excited to do this webinar, take on the task of putting a new deck together for this purpose is I believe the limited understanding out there as a newer diagnosis with a funny name. I believe this limited understanding poses a lot of challenges to effective recognition, treatment management, and that spills over, of course, into delays in accessing much needed treatment that impacts growth, development, nutrition. And so let's forge ahead. I won't read these because you can read them and find them anywhere, but just to highlight a couple things from the DSM-5 criteria for ARFID is there's this failure to meet appropriate nutritional energy needs, and it's not better explained by lack of available food. That may go without saying, but important thing to point out. And it doesn't occur exclusively during the course of anorexia, and it's not attributable solely to a co-occurring medical condition, or better explained by, say, autism alone or another mental disorder like a depressive episode with loss of appetite for X number of weeks during that episode that resolves with the mood, for example. And those can be a little hard to tease out, but I wanted to point them out from the criteria. Um, and the eating disturbance, when it does happen in the context of another condition, as ARFID often does, like with autism spectrum disorders, the severity of the eating disturbance needs to exceed what would be typically associated with autism without ARFID or kind of traditional autism. So where did this come from? And what's the history of ARFID before that DSM-5 when it was added? Because if you think about our unit where we have, say, 20% or our units in programs, 20% of people roughly with this diagnosis, what did we do before? We had this, and I understand, and the first to also get on a soapbox about the concerns with labels and diagnoses. But as a researcher and clinician using, insurance wherever available and using diagnoses to study conditions as focused as possible to try and find new treatments. These are also important, and while an imperfect science and an evolving one, it's it's a necessary one that helps us both research and treat and get on the same page and have a common language and framework. But if you look back, say, pre-20th century, there were kind of astute clinicians and others, often pediatricians, recognizing this picky eating above and beyond what might be typical development. And they didn't have a psychiatric framework for that. But in the 60s and 70s, there was this infantile anorexia, thought of as a pediatric feeding disorder, a feeding disorder of infancy, and often recognized in infants, toddlers, linked to maybe oral motor dysfunction, um, and poorly understood, and largely at that time limited to very early childhood, not really considered in the broader spectrum of eating disorders at that time. Um, and then, so 1980, around the DSM-3 era, there was this feeding disorder of infancy or early childhood, formally in the manual of diagnoses that had criteria focused on failure to eat adequately, leading to weight loss or failure to meet milestones. And the onset in this early diagnosis was restricted to under 6 years of age. So it didn't really account for, didn't really account for, I'm hitting the wrong button, for older children, adolescents, adults. And then beyond that, with that diagnosis there and being kind of tried on out in clinical settings in the wild, if you will, there was growing recognition of this atypical restrictive eating and increased awareness, increased discussion in, conferences, clinical circles, research meetings, like children with selective eating, food-related phobias, sensory sensitivities, including in autism. And so this selective eating disorder term was kind of used informally um, to describe these kids who would only eat a limited number of food due to smell, texture, fear of choking. And there was also this recognition that this unique eating disorder didn't have the same kind of concern of weight and shape. And so then in the years that followed pre-DSM-5, there were these working groups and discussions to come up with a classification. And they identified this issue with the DSM-3 classification about what about older children, teens, whether or not it clearly has its onset in early childhood or childhood in general or not. And this new diagnosis was proposed. And so that's uh that's where we are now. So since what going back to the DSM criteria, 2022 would be the DSM-5 TR formal year. And so since that time, you have a lot of case series, little studies, more research. We'll talk about some of the like manualized treatment approaches that have come out and some that we use. I'll talk a bit about our program and more understanding of the neurobiology, kind of a surge in studies on sensory processing networks, how do fear circuits tie into this? What is the estimated heritability? And what do we do with adults with ARFID, or what do we call that? What is really the potential range of onset and the age range and the driving forces, and then increased integration in centers like looking back at ours, we've had this revamped kind of approach to the meal plan and a track and specialized groups, if you will, for say the last year or more. And I suspect with our center and the field as a whole, we'll continue to evolve together, and discussions like this help us, share lessons learned along the way. And so this is just a recap, and you can look at these slides. I included a little more than we'll have time for, I think. I never quite know until we get into it, but you can look at these on your own. I've summarized that timeline on the last slide, but just a little bit more on why this was needed. So before we had ARFID as a diagnosis, um, many, or if not most, kids with these kinds of eating disturbances who didn't meet criteria for anorexia, bulimia, for example, were diagnosed with say, an not otherwise specified, an OSFED and EDNOS kind of vague catch-all. And if you look at studies prior to the DSM-5, um, it gets kind of striking in that maybe 50% in some studies of pediatric populations with significant eating disturbances were diagnosed with not otherwise specified kind of eating disorder. There's a couple 2011 studies that I put up here, where EDNOS in that Swanson study was more common than both anorexia nervosa and bulimia nervosa combined. But the problem is that this catch-all bucket diagnosis, of course, was too broad and heterogeneous, and it included everything from like subthreshold bulimia to atypical anorexias to non-body image related restrictive eating. And this, of course, made it challenging to go for insurance reimbursement, to go for funding for new studies of therapy approaches, drug trials, etc. But obviously the kids and adolescents and adults with these kind of struggles were being seen in clinics, and there were these sensory-based aversions and post-traumatic feeding disturbances, um, and other things that just really highlighted the need for it. So and these were also complex cases that require, and we'll talk more about this, tailored treatments and a multidisciplinary approach. In fact, some programs really include occupational therapy in ARFID treatment, for example. So let's kind of forge ahead a bit to how common is ARFID. And as a newer diagnosis, the body of research on this topic is still growing, but I've kind of broken it down by population. So if you look at the prevalence of ARFID in like the general pediatric population, you might land somewhere between 1.5 to 5%. Like a school-based study in the US showed 3.2% of children aged 8 to 13. Um, and if you look at pediatric specialty clinics, like an eating disorder clinic, it might be 5 to 20+%, or in a feeding pediatric kind of feeding clinic up to 60+%. And if you look in other settings with children with chronic medical conditions like GI and other food-related things, it gets quite high as well. And then if you look in those who are no longer children or adolescents in the adult population, like a community sample might be, a third of a percent to 3+%. And there's still work to be done on this, on the trajectory of ARFID and the age of onset, the potential age of onset. And a UK study showed like a 1% lifetime prevalence in adults using structured like diagnostic assessments. So I think that gives you a feel for what kind of prevalence rates we're looking at this stage. And and gender distribution, unlike anorexia or bulimia, the male-female ratio appears to be about the same. And some studies even suggest that in those with neurodevelopmental conditions like autism spectrum disorders, for example, there may even be a slightly higher prevalence rate in males. Nothing concrete on that front, but it's interesting, and also makes sense given kind of what we'll talk about in the kind of the etiology of ARFID. And so here are some rates of common comorbidities. I like to go through this for any given eating disorder we're talking about, of like with anorexia, for example, what percent of individuals with anorexia nervosa will meet criteria for generalized anxiety, OCD, depression, et cetera, and how does that compare to bulimia, binge eating? And you can almost start to guess based on the pathophysiology, and like we've been discussing with ARFID, autism spectrum disorder is kind of known and well accepted to be fairly commonly associated with ARFID, or at least, you know, one of the types of ARFID. ADHD, quite high in its prevalence, tied to it, generalized anxiety, and also OCD has rates that you might see similar to the comorbidity rate with anorexia, for example. Um, and if you look at the subtypes. The next question kind of I have in trying to think about how common is ARFID is how common are the different types of ARFID? And in clinical samples like eating disorder programs, you would have the sensory sensitivity type being most common, and then say the low appetite, low interest type, and the fear of adversive consequences or post kind of traumatic feeding incident or incidents would be a lesser rate, but still quite high. And important to note that there's a lot of overlap. There can be upwards of a third in eating disorder programs who might have two drivers of their ARFID rather than just one clear one. Um, and so if you look at pediatric settings, the rates aren't that different. And but if you look in like neurodevelopmental samples, of course, the sensory subtype would be most common. And in a pediatric community setting, you'd have the kind of low interest in food, maybe even a little more common. Mind you, this is just one study from 10 years ago, a large, relatively large study, but so I couldn't tell you how these numbers would land if you did that with a study of 10,000 today, for example, but I think it gives us a general idea. And so what I take away from that is that, sensory-based avoidance seems to be consistently the most prevalent subtype across clinical samples and community samples. Um, and the least common might be the fear of adversive consequences, but still quite common if you look at overall prevalence, and still where in some samples it could be 10 to 30+%. And there are many individuals with overlapping subtypes, or you could call mixed features. And so, what causes ARFID? Before we started, I was talking to Tamra just about life um and how my twins are now 16 years old, and she mentioned, oh yeah, I remember seeing a slide of them years ago when they were babies, and I didn't have that in this deck, but while waiting for you all to join, I had like 2 minutes to spare, so I dropped it in, even though that's, you know, highly illegal because you already have the slides and they're downloadable in original form. But this is just bonus material, let's say, to talk about genetics because I have this picture I took way back. My twins are identical and they're now 16 and driving. But this is when they were babies and when crib nets existed. They've since been recalled. And I put it up there because it's been really, really interesting and super rewarding and also super wild at times to raise twins. And having done a fellowship myself in neurodevelopmental genetics after my residency at the University of Utah and done a lot of work in autism genetics and other psychiatric genetics early on, um, I get really interested in this question of nature versus nurture. And I don't even like the question. Like, I don't think it's ever I, I shouldn't ever say ever or never, but it's nature plus nurture, I think is much more accurate rather than nature versus nurture because there's always um, genetic susceptibility, nearly always, and their environmental influences in some other medical specialties. You might hear sayings like, I don't like the sayings necessarily, but they're telling like genetics loads the gun, environment pulls the trigger. And so there's this perfect storm of biopsychosocial factors often that goes into the development of a given mental health condition. And so here's another slide I just dropped in as bonus material that you don't have, but I put it up only to show how things like autism rank on the heritability spectrum, schizophrenia, bipolar, ADHD. And as you get into like anorexia, bulimia, you're in a typical range for DSM-5 mental health conditions of like say 40 to 60% heritability is where a lot of things will land. And heritability just means, I guess, in an oversimplified definition, the percent of risk of developing a given condition that's from your DNA or your genetics. Um, and then in the case of ARFID, there are certainly environmental influences like the subtype of ARFID where there are traumatic feeding experiences like choking, vomiting, food poisoning, leading to an understandable food-related fear and understandable avoidance and a conditioned aversion to food. Like maybe it's not that unlike this example of a little toddler who the minute he's coughing, if he doesn't have a cup of water right there, whether he's going to drink it or not, he's going to throw up. Um, and those things can get coupled, and just like they can get coupled, they can get uncoupled in treatment. And treatment is not easy. That's an understatement. This is very, very hard work, and I have a whole lot of compassion for those doing it and the families supporting it as well. Um, because you're often facing full-blown, fight or flight level fear circuitry in going through this doorway of refeeding and nutritional rehabilitation to get back on track for getting the sustenance you need to go about life. Um, and so these aversions, of course, persist long after the threat is gone, like in PTSD, for example, in different manifestations, and especially in individuals with a certain kind of perhaps genetic or even environmental primed sensitivity to high anxiety and fear. Um, and there, so every time I start to talk about family dynamics, I want to set the stage by saying um, families are the number one allies for recovery, and family-based involvement is is always, again, I'm not going to speak in ultimatums, but should be the norm and the rule, and whatever the family dynamics are, if we can do the work together, heal and grow, and support one another through that, very difficult work, then I think that sets up the best path forward towards recovery. That's never a linear path, but there are family dynamics that can fuel ARFID type pictures, like extreme pressure to eat, or using food and reward, food as reward or punishment in significant ways for some kids who are especially susceptible to the impact of anxiety provoking meal times, high conflict, etc., can contribute to the onset. And there are cultural norms as well. It's interesting. Culture plays a huge role in many eating disorders, of course, and in ARFID, in even without the body shape and weight driving forces for most people, there are these cultural norms around cleanliness, food safety, body purity that can also drive it, or some cultures with rigid food rules and things like that could maybe accidentally reinforce uh, or kind of kick off the path towards development or something of the like this in the perfect storm of biopsychosocial factors. And then as I mentioned, especially since the DSM-5 ARFID diagnosis has been rolled out, more and more studies have been done on the condition with this common framework and ability to get funding and insurance reimbursement, leading to populations that could be looked at too, not just to treat, but to participate in studies or go back and look at data later. And there's some imaging studies, for example, showing um, showing some kind of altered circuitry in the amygdala, the insula cortex, areas around fear, around interoception, around disgust, and there are imaging correlates to the heightened sensory sensitivity. Um, and then in twin studies, that genetic slide I showed didn't have ARFID on it, but twin studies, when you look at, by twin studies, I mean you have studies of what's the rate in identical twins, what's the rate in fraternal twins, and it gets really interesting uh, when there are studies done of like what's the rate of a given condition in identical twins reared apart and versus fraternal twins versus siblings in general and first degree relatives. Um, and there is this heritability that gets up there that's estimated with ARFID closer to the 80% mark than, say, the 55 to 60% that might be the the prevailing estimate for something like anorexia or bulimia. And there are shared genetic risk factors that have been identified with not only autism spectrum conditions, but OCD and certain other traits that relate to the things we've been talking about. And so that leads us to this question of, okay, what are the mechanisms? What are the forces at play? Oh, one, just to kind of break them down into a few, there's the sensory processing differences. So individuals with ARFID uh, may, especially with that sensory type of ARFID, have this heightened sensitivity to taste, smell, texture, and this is correlated to the heightened reactivity in certain sensory areas in the brain, and the overlap I mentioned with ASD. And this can lead to that aversive conditioning and fearing foods, eliminating many foods and groups of foods, or fearing food in general. And then ARFID can also develop through this kind of fear-based learning and conditioned avoidance, like when it gets paired or kind of inappropriately coupled with pain, choking, vomiting, maybe not even inappropriately, but persistently coupled in a maladaptive way. Um, and you see again, the amygdala, insula, anterior cingulate cortex come on board in altered ways. And if you get into some of the trait anxiety, you can see the anxious aversive subtype showing kind of a high intolerance of uncertainty. So when we talk about approaches to treatment, like some approaches to treatment will even include not just exposure to new foods, but exposure to novelty in general, which I think makes sense, especially for some individuals where there's this big. I mean, we all f fear the unknown, but we all fear it to a different degree and in different ways. Um, and then a couple mechanisms, and I'll pick up the pace so we can leave time for questions. But interoceptive dysfunction, like this alteration in the ability to sense into hunger, fullness cues, and also with some neurobiological evidence, growing evidence to support it. And I think the last mechanism I'll mention is differences in reward processing. This is also relevant to many eating disorders, but in ARFID specifically, you might have a reduced impact of the reward value of food that just maybe there's not that same dopamine spike after, and that with dopamine sometimes being called the molecule of more, or the thing that has evolved for the survival of our species, both in reproduction and food and things like that, and also the thing that can get people in trouble with habit loops and things like that. In the case of ARFID, you might have an alteration to a dopaminergic pathway or reduced activity of reward circuitry that contributes to this inability to get oneself to eat. And so let's talk about how it's detected, screened, diagnosed. We've already looked at the DSM criteria, and I just put them here because um, that really is like when in doubt, you have the DSM criteria, you have your clinical judgment, and you have the individual, all the other kind of supporting information from family, caregivers, past treatment settings, teachers, etc. And you can go through these criteria. And then we have this kind of this evolving definition that really categorizes the subtypes that can, as I mentioned, be overlapping. But say you want to screen for ARFID quickly, there is a brief self-report questionnaire to screen in both adolescents and adults. Self-report, they're not typically given to little kids. That's why they're not mentioned, because you got to be able to reflect on oneself and fill out the questionnaire. But there are three subscales on this brief 9-item scale that can also point towards what type it is, and it's validated in both clinical, non-clinical settings, often used as first line um, screening. And so if that's not in your toolkit, you may want to check it out. I'll put it up on the next slide, but um, not a diagnostic tool like any screener, but something like the PHQ-9 that has been rolled out in primary care settings and so many other settings. It has a really sensitive ability to pick up um, depressed mood and suicide risk factors. So then if someone does screen positive, that's when you're going to sit down with them or refer to specialists to sit down and go through those diagnostic criteria, and you can consider one of these other tools. But I'll skip over the 9-item screener because you can Google it. It's freely available, or you can look at it in the slide deck, try it out from there if you'd like. But there is an EDE. The EDE is like when we do clinical trials, we'll use the EDE. in general. It's existed for a while, and it's this semi-structured clinician-administered interview, eating disorder examination, and there's an ARFID version or focused version to provide a way to do a comprehensive standardized assessment. It may be more commonly used in research settings, but can be used clinically. And as a kind of a researcher, that's one thing that I pull into my clinical life is what I learn from these rating scales and assessment measures, and specifically using them sometimes to support my clinical decision making and to track progress, quantify things over time. Um, and so the other thing that I wanted to point out on the assessment tool front is this diagnostic interview called PARDI. That stands for Pica, ARFID, and Rumination Disorder Interview. So another fun name. And this is somewhat of a broader tool. If you want something that, if you're not really zeroed in yet, and there may be things like rumination disorder or pica, things like that. I won't get into those today because we're going to run out of time. But it goes through in a systematic way the diagnostic criteria for each, and you can also Google it and find it online. And I put a link in the slides. So what do we do? There are no what do we how do we approach ARFID? And I'll first point out that as of now, there are no formal international or national consensus treatment guidelines like you see published by certain groups, like the APA does for ANBN, and like you see across, um, the treatment guidelines, consensus guidelines, standardized protocols. And there are a lot of kind of clinicians and researchers highlighting the urgent need for more of this, but and it's coming as the research evidence grows, and as our kind of collective knowledge as a field progresses. But I'll point out a few things that do exist, including one, the first one that we use the workbook quite commonly at Center for Change, but there are these two researchers and clinicians, both psychologists at Harvard, doctors Eddy and Thomas, who were actually co-directors of the Mass General Eating Disorder Research and Treatment Program, who wrote Cognitive Behavioral Therapy for ARFID. So I would consider this the most developed manualized treatment model, as they developed it and published a paper on the kind of feasibility and some initial data on using that. And it has this psychoeducation approach to exposure to new foods, fear hierarchies, relapse prevention strategies. There are maybe 20 to 30 sessions across 6 to 12 months in this CBT manual. And there's a workbook. So the workbook is, what's it called? Um, Okay, I have it in a future slide, but there's a workbook by the same authors that we give to all of our folks with ARFID who admit to these programs that I was mentioning. And there are FBT adaptations for ARFID. There's even this thing called SPACE. SPACE is if you haven't heard of it, space-ARFID. SPACE is supportive parenting for anxious childhood emotions. And there's an ARFID adaptation, and it's a parent-only treatment model by Eli Leibowitz at Yale, who's done a lot of work on treating child anxiety, and it targets the parental accommodation, helps them kind of reduce these accommodations gradually. But I point that out. It's not on the slides, but I point it out because a question might come up of what do I do, given that ARFID can come on early in childhood? What do I do if a child is too young for CBT or unable to, or refuses like therapy, and too young for for CBT in general, I think most kind of CBT experts would say that around age 7, and it depends on the kid, around age 7, you'd start to have that ability to reflect on internal processes and the nomenclature for describing them and the ability to try some of that on and challenge things internally. Um, so let's talk about pharmacology. And um, there are no FDA approved treatment options for ARFID, just like there are none for anorexia. But there are all sorts of medications out there that, in the absence of formal options, that some clinicians use off-label or for co-occurring conditions. Like, I'll just mention a few, not an exhaustive list at all, but like some might consider mirtazapine, an antidepressant that is used sometimes for appetite stimulation and sleep and anxiety reduction. And there's a reference I posted that can support that a little more. Olanzapine, Zyprexa, you might think of in like really underweight treatment-resistant cases or where there's comorbid, like serious OCD traits, rumination, etc. There are SSRIs similarly for co-occurring anxiety, OCD, and I'll point out just briefly that when treating OCD or OCD related traits with SSRIs or with almost anything, I think I need to fix my slideshow here. There we go. Often higher doses are needed. Like you might find success with 50 to 100 milligrams of sertraline or Zoloft in a child adolescent kind of mood disorder case, like MDD, for example. But like with the severe OCD, more commonly than not, I would say you have to push the dose higher. And there are no randomized controlled trials yet for drugs, like prospective, forward-looking, big, adequately powered studies, specifically targeting core ARFID symptoms. And I hope these are coming. And so these medications that I mentioned, I would consider them adjunctive, not the mainstay of treatment, and always to exist in the context of a multidisciplinary treatment approach. Um, and potential candidates for adding on a medicine off label might be those with like comorbidities or co-occurring anxiety that gets in the way. Um, Hard to participate in the therapy due to that fear and avoidance that comes on drastically and serious disturbances in appetite, sleep. So I'm going to skip over. There's more evidence that you can review on your own if you'd like on the medications I just mentioned, but I want to get to our questions. So um, just a note on early intervention is key. They say that in autism. I remember that kind of drilled into me very early on when doing research and clinical work in autism early career of early intervention is key. The quicker you can detect and plug into any of these interventions we're talking about, especially psychotherapeutic ones, the better the outcomes. It does not mean that all is lost if it goes unrecognized. But but if you look at these studies, children who diagnosed and plugged into treatment earlier did seem to have a smoother, swifter trajectory towards recovery. And by early intervention, just for research definitions, it's often considered like within 6 months of clear-cut symptom onset. Um, and so in one last thing I'll mention on the kind of the natural course and prognosis is ARFID typically has better physical recovery rates than anorexia nervosa. Um, and this is not super clear and a well-founded conclusion yet, but just talking about general trends that are being seen, like ARFID clients may regain weight faster, but and have fewer medical complications associated with the kind of anorexia specific, like starvation or the purging seen in bulimia. But ARFID may have slower or may need a kind of a slower, more drawn out course for improvements in the food flexibility and because these patterns do have somewhat of a, in some cases, a sticky kind of neurobiological underpinning that can take time, like physical therapy after healing from kind of an injury. And ARFID is not egosyntonic, like aligned with self-image, but the avoidance can be deeply rooted in fear or deeply rooted in one's sensory wiring. And I'll highlight a couple of these is education is advocacy. So we're here talking about this, and I think the more we can spread the word and spread good information on the topic, the more early intervention we'll have. And another important point, I think, is don't equate weight restoration with full remission. There's that kind of psychological flexibility component that is huge. Well, there's my alarm to move into Q&A. Um, so um, treatment goals should include expanding variety, not just eating. Like parents may have a kid come into our treatment center and say, great, they're going to come in, eat a bunch of vegetables, but we're going to start by getting them to eat food. And then we're going to have it a goal to make it part of their routine and help them enjoy food. And rather than have to, say, set an alarm to eat their whole lives, for example. And relapse prevention is crucial. Symptom resurgence, kind of relapse into some of these patterns is quite common and certainly a big risk when transitioning or stepping down from more structured environment to less, even from, say, residential to day treatment and from day treatment to IOP or outpatient. And we don't have time to get into some of these relapse prevention strategies, but I will just stop there and we can talk about some of these other lessons learned in the questions or whatever else you'd like. But thank you so much for listening and looking forward to chatting with you about your questions.
Thank you, Dr. Robison. Will you stop screen share for just a minute? We're just going to do a couple of quick reminders before we know we have lots of providers on. And so we sometimes you have to hop off at the top of the hour because you may have clients. So I want to go over this real quick before we get to the top of the hour. Then we'll go to questions. So as a reminder, if you have a burning question that we don't get to, and we're not gonna, we have like 200 questions. So there's no way we can get to all of them. So I'll do my very best to pick some that maybe might be relevant for lots of folks. But if there's a burning question you have for Dr. Robison that we don't get to, feel free to email me at cfcwebinar@gmail.com. Excuse me, and I will pass it along and we'll see if we can get your question answered. Okay, when I click to end the webinar or you leave before it's finished, you will see the webinar evaluation that will pop up on the screen that you're looking at currently. And if you would just take a minute to answer those questions, we would really appreciate it. This is a continuing education requirement for us. Your responses are completely anonymous, so feel free to be candid in your feedback. We tabulate those results, send them to the CE providers. And then when the webinar ends or you leave, you will see in a new browser tab the link to take the online post test. If you would like, you're welcome to take out your phone right this second and scan the QR code. And that QR code will also take you to the post test link. You will also receive a follow-up email tomorrow with the link to take the online test if you haven't done it already. So you've got lots of options. You must take the test online in order to receive continuing education credit. Once you complete the test and pass it, then the CE certificate will be available for download. So please take a look for that. Okay, I'm going to stop screen share. I'm going to get to questions.
I just answered one.
Oh, fabulous.
Two, I'm gonna do it again here in the chat. But
They can't see the chat.
some people asked about what space is and who the researcher was. So I put it in the answered questions if you want to get it there.
Oh, perfect. Okay, thank you. Okay, this is from Janae. Janae asks, when this is connected to autism, how does it look different? Is it treated differently in that population?
Yeah, it's a good question. And maybe a tricky one to give a concise answer to, but it looks different because it has uh, more picky eating and more impact on one's life than autism does typically. And like it would have a more extreme variation of some of the food and texture and sensory and smell and other sensitivities. Um, Whether these are folks with just a higher propensity to the sensory stuff related to food and texture, or whether something happened along their path with autism that really made food a focus of some of that autism kind of pathophysiology, if that makes sense. And how it's treated is you need, and why I mentioned multidisciplinary is key to this is, it takes a village, if you will. It takes um, specialty in both kind of working with neurodivergent individuals in therapy in general and specialty in um, their eating related concerns, ARFID, etc. So I think I'll just leave it there, but it's similar plus. Like you've got to kind of still pay attention to the autism treatment needs and continue to approach those holistically and also add things into the equation to treat the food related disturbances.
Thank you. All right, Leah asks, many clinicians are seeing clients with ARFID that began in childhood evolve into body image concerns as well. What are your thoughts around treatment approaches when both ARFID and body image distress / drive for thinness are present?
Yeah, it's a good point because I think that's what one thing that struck me early on in my kind of my work as medical director at Center for Change is the diagnostic switching that can happen or the evolution of one's clinical picture on an individual basis over time. And it doesn't surprise me that you'd see some folks with that kind of picture. And I think then all of a sudden you don't have someone without the body image concerns to address. You have all the ARFID concerns and you have some body image concerns. But I think, so it may sound more complicated in that regard, but, and I wish we had time to hear your experience and, would love to continue this discussion with everyone in whatever way going forward. But you still got to treat the ARFID and work on the body image component. But just like ARFID can have overlapping categories within ARFID, ARFID can have overlapping categories outside of ARFID into other eating disorders and beyond.
That makes sense. Thank you. Hannah asks, how effective is internal family systems for ARFID? Seems like it would work well, but wondering if we don't have that information from research yet.
Yeah, we don't have. I'm a fan of internal family systems. I've done formal training with the Institute, and I think my last webinar may have been on internal family systems with ketamine for eating disorders, for example, or one last webinar. But there is very little data in the literature on internal family systems in general. There is a little bit on eating disorders, a little bit on PTSD, mood conditions, none to my knowledge in ARFID, but I think it needs to be done. I think what you're going to run into is, this may go without saying, but just the age of development and ability to engage in kind of part works as one factor. but I think eating disorders uh, are kind of eating disorder treatment is parts work more than we give it, more than we even call it that. Like if you have a center where everyone who comes in gets a copy of the book Life Without Ed, it's one oversimplified part of the eating disorder personified as ed. And I think the more we can kind of build on that and look at this symphony of selves that we all have inside ourselves, like I think it could be really helpful to weave into ARFID, and more research needs to be done. And I don't see any concerns or major kind of red flags for having that as one of the tools in the toolkit when approaching it. But yeah, I would love to hear people's experience who have worked with this, and feel free to add anything in the chat if you have some ideas there.
Thank you. I have a couple of questions that are similar, so I'll do them both, kind of combine them, and you can maybe point us in the right direction. So Charlene says, when someone has ARFID as an adult, can this be more pronounced in geriatrics? And Linda asked, I have an older client that's failing to thrive, as saying she does not like food, the taste, or desire to eat. So they're similarly related in that geriatric situation. Do you have any comments or thoughts about what that might look like in older folks?
Yeah, it's a good question. It's a good question. And to to circle back to what we were talking about, I think very early on is ARFID can affect children, adolescent, adults, and the elderly included in the adult population. And um, there is this other part of it that we were talking about where it's not attributable to another medical condition, or not explained by either another medical condition or another mental disorder. And that would include things like Alzheimer's. And so you could have a picture that looks like ARFID on the surface, but maybe there's something clear cut medically or psychiatrically or neurologically that explains it. And this is kind of a caveat that exists in the DSM all over the place is, what's primary, what's driving what, and not an easy task sometimes, but I think. ARFID has this general theme of coming on for most people in childhood, if not childhood, adolescence, and it doesn't mean it cannot come on later in life, and it certainly does in some situations, whether it's traumatic or decreased interest. But I think it becomes just more and more important to do the ruling out of other things, and that's where those structured assessments can be helpful, like the ones I mentioned, but also if you're not familiar with something called the MINI, MINI, it's a uh, neuropsychiatric diagnostic interview. We use it all the time in clinical trials. If you've heard of the SKID, it's a quicker version. Like it's supposed to be half an hour. It's usually more, and you can Google it. I think uh, find a sample copy. David Sheehan, who made the Sheehan Disability Scale, he developed it. And it's a nice way to go through in a systematic way, just ruling in or out different conditions. And I think those kind of approaches, even if it's in your own algorithm, can help. I don't know if I'm fully answering it. It's a really good question, but those are some initial thoughts.
Thank you. We'll do one last question, and then we'll let folks go because we know it's getting late, past the hour. I liked this question because, to be honest, physicians tend to get beat up in our webinars sometimes because they don't always, not you, Dr. Robinson, but physicians who
Mhm.
are, pediatricians or general practitioners who maybe don't screen for eating disorders or don't get a lot of training. And this question speaks to that. Nora said, do pediatricians screen for ARFID? And my
Mhm.
thought is probably not, but I'll let you address that. And I would add a second piece to that, which is how can clinicians and even parents, I think we have some parents on today as well, how can they advocate with their pediatrician to get screened for ARFID?
So just like there's this much needed haze movement out there, health at any size, and much needed focus for the broad population of like clinicians of just being aware of eating disorders and some important approaches to it. Um, I think we need similar kind of education around ARFID, but pediatricians are, I think, some of the most experienced with this phenomenon. And where ARFID comes from is astute pediatricians saying, what do I do with these extreme cases of picky eating causing failure to thrive and failure to meet milestones? And I think I give pediatricians in general a lot of credit. And sure, they are too busy to systematically screen in most clinics. And do I think that 9 item scale could be used? Well, no, it's like you can't give a self-report one to a little kid, but should something be given to the parents around that? That would be great. And I think we need more of these validated, easily accessible, freely available tools. But I think my view is that pediatricians are pretty, uh, certain, some of them especially pretty well versed in um, picking this up in their clinical encounters and recognizing, okay, when do we need to refer? Um, Not all, but and there's certainly more work to do there. But that's my sense at this stage.
That makes my heart happy to hear that. It really does. Thank you. My thanks to Dr. Robison today. My thanks to all of you for attending. We recognize that it's time out of your busy days to spend time with us, and we're really appreciative that you would. And we wish you all well and stay well and enjoy your summer. And we'll see you next time. Bye,
Thanks,
everybody.
everyone.